I have the pleasure of introducing Dr. Justin Iwasaki, MD, MPH. Justin has worked in multiple communities around the world, developing innovative solutions to complex health problems. He previously served as the executive director of the Lummi Tribal Health Center, where he launched a hepatitis C elimination program. He continues to work with the Lummi Nation on special projects, including directing an opioid overdose prevention program. He's also the co-founder and chief medical officer of Tribal Health Connections, a healthcare company working to increase access to virtual specialty care in tribal communities. He has designed and led projects with funding from the CDC, the Bill and Melinda Gates Foundation, Center for Medicare and Medicaid Innovation, and his work has been developed into case studies by Harvard Business School and the Stanford Design School. He holds a clinical faculty position with the University of Washington School of Medicine and completed a family medicine residency at the University of Washington Medical Center in Seattle, Washington, with concentrations in bioinformatics and global health. Prior to that, he graduated from the University of Utah's combined MD-MPH program, where he was involved in the startup and impact investing community. Justin will be speaking about the Lummi Nation Hepatitis C elimination plan. Dr. Iwasaki.
We're going to give an overview of the program that we started at the Lummi Tribal Health Center. Hopefully a lot of this information now is old, actually, that people have been engaged in this work for now multiple years, and that people have actually implemented a lot of these strategies in their own communities already. So we're going to introduce a design framework, which is the way that we thought about our programs, talk about the components of a Hep C elimination program, which echo what Jorge just mentioned, and then reinforce the need for harm reduction. So I'll go back. We're, just for context, we're located in the Pacific Northwest. It's a Lummi Nation. We have a tribal population about 5,000. We're semi-rural. Closest city is Bellingham, which has about 150,000 people. The tribe is predominantly a fishing tribe, has the largest commercial native fishing fleet in North America. Next slide. So in 2014, just for timeline, we had no hepatitis C treatment. We referred all our patients out. There are huge restrictions on access to care for a lot of our patients. In 2016, we started our program, and we'll talk about how we started, and then we'll talk about where we're at today. So we started treating hepatitis C again in 2016. It was right when the DAAs were coming online, and we saw this problem that a lot of our patients had been diagnosed with chronic hepatitis C, but were unable to access specialty treatment even locally because of restrictions around substance use disorder, untreated mental illness, homelessness, issues that prevented them from accessing specialty care in the way it was already typically being provided. And then the access to DAAs came available and made it possible for us to actually take this on. Like Jorge mentioned, locally, the vast majority of our patients are young, and the vast majority of patients with chronic hepatitis C have a history or current injection drug use. 80% of all of our cases, this is from Jorge's data too, but it echoes exactly what's happening with us. The majority of our patients have active injection drug use. Next slide. I think this was mentioned also, but as people begin injecting drugs, their likelihood of contracting chronic hepatitis C goes up pretty dramatically within a few years of initiating injection drug use. The majority of our patients, it's probably similar, many of your communities are not new with injecting drugs, and many people have decades of experience with that, and with that comes chronic hepatitis C. Next. Our own data showed that 4 out of 10 patients at our opioid treatment program tested positive for hepatitis C antibody. The opioid treatment program in a patient population about 5,000 on the tribe had about 280 unique patients in a year, for context, and 4 out of 10 of them screened positive for Hep C antibody. Next. And out of that group, 50%, half of them are under age 40. So I think our patient population really mimics the national data. Lots of young people with chronic hepatitis C related to injection drug use. because of the way that hepatitis C is typically spread now through injection drug use, is clearly a public health problem. And as Jorge mentioned, the context around injection drug use and then therefore hepatitis C is a community problem and not can't be addressed with a typical clinical model. Next slide. So when we started this program in 2016, we actually started with this notion that we would treat everybody who had hepatitis C in the community, regardless of their current drug use, regardless of untreated mental illness, or at that time in Washington State were some of the requirements for actually accessing the medicines. We actually, when we started this program, the term microelimination wasn't even in the vocabulary. And so when we were talking about this, we would talk about it in different terms, but fortunately we have this term now. But the goal for us was always to treat folks who treat every person in the community who had chronic hepatitis C. Next slide. And to do that, we were screening and treating very high-risk patients, meaning patients who are actively injecting drugs, and that was a very complicated task at first. It continues to be, but it's become a lot easier. We adopted the notion of treatment as prevention. As you treat more and more people for chronic Hep C, even if they continue to inject drugs, they're not spreading the illness, the virus. And we adopted harm reduction strategies pretty aggressively. Next. I'll give some background about how our program started and hopefully give some permission to make mistakes for everybody who's engaging in starting these programs. When we first started doing this in 2016, it would take us up to 4 to 6 months to get somebody treated. So we'd screen folks, it was really clunky. We'd screen them for an antibody, we'd get more labs, we'd diagnose them, we'd have to get liver imaging. Typically that was a referral to an outside imaging center for an ultrasound. Then the process for accessing medicines was extremely cumbersome at first. It's fortunately become much better in Washington with changes in the Medicaid rules. Then we'd get them the medicine when we'd follow them up. And it was taking forever at first. And this was back in 2016. So we realized really early on that the way that we were doing this, which was really a clinical model at first, really wasn't meeting the needs of our patients, especially patients who had active substance use disorder. Next. So I think we could do this exercise for lots of different programs, but what we went through mentally, like what is our program really designed to do initially? We expected patients to come in for scheduled office visits and to follow up when we asked them to. We expected them to have the ability to store the medicines. At that time, we're using Harvoni, which was $80,000 a treatment course. We expected them predictable telephone numbers and ability to follow up, and we expected them to have family support to help them. But what the people actually needed was incredible flexibility. They needed to be able to show up whenever they needed or were able to show up. They needed rides to appointments, even if that was half a mile down the road or a mile down the road. They needed help managing medicines, and we partnered with our opioid treatment program, who was doing directly observed therapy for opioid use disorder, to also hold the medicines also hold the patient's DAAs. They needed incredible outreach, and they needed really a lot of support to get through the process. And that's what we had to design. Next. So really and this is a philosophy that we've continued to bring to a lot of our programs. We really need to redesign the healthcare experience for people who use drugs. And that's not just for Hep C elimination. We're thinking about that for our OBOT program and a lot of other programs. Now with getting coronavirus vaccines to people, this idea continues to permeate a lot of our work. Next. So we worked with the Stanford Design School a few years ago. A group of us went to a 2-week workshop and really got a lot of great vocabulary and framework for how to think about the things that we're already doing. So when taking a design thinking approach to these problems, it's really that exercise that we showed just a second ago with the 2 columns, really thinking about why do people act, think, and feel the way they do, and really trying to get the heart of understanding, like, well, why aren't they coming to get screened. And once they get a positive antibody, why aren't they coming back for the labs? And what can we do to make that easier for folks? And then really thinking about a point of view, like what do we really think is happening for folks? Creating a mental model of what's happening in people's lives and how do we begin to address the potential barriers that we think they're faced with. And then just thinking broadly, like coming up with lots of different solutions and not being afraid to try multiple at the same time. Prototyping, I think, is something we don't do that often in clinical delivery. I think we get in our own way a lot and overthink things, but really this concept that you can try things, experiment with different models of clinical delivery and then learn from that and continue to iterate and make it better and better. Next. So what we learned through all this process and where we are today is we actually realized that we had to hire dedicated staff to do this work. So the program actually required nearly full-time people managing healthcare information, the outreach programs, accessing medicines. And what's also interesting is the folks that were hired to do the Hep C elimination by default and naturally became our harm reduction staff. So now they're one and the same. The job titles are basically Hep C elimination and harm reduction is essentially the job descriptions for our folks now. They walk folks through all of the process to get treated and access medicines and follow up, but they also do all of our harm reduction at the same time, which makes a lot of sense. We had to streamline a lot of our internal workflows, both with the EHR and lab ordering. We're fortunate to work with the Portland area to get an on-site fibroscan, which really expedited our ability to deliver staging because it was right down the hall and compressed the time that we can get somebody staged for treatment. And medication management's become much, much easier now with changes in this Washington State Medicaid program, and then doing follow-up and outreach, which is really extremely critical for getting people treated and then making sure they continue to take the medicine. Thanks. So we can, hopefully these slides will be shared, but we essentially took that long 4 to 6 month process to get somebody treated and compressed it into a few days. And really, it came down to just figuring out what was needed from the patient standpoint, what was needed from our standpoint to make sure we could safely stage someone to get treated and then get them the medicine. So now this is essentially the workflow that we have, and someone can get treated within a week or so. And the week is really waiting for the medicine after we order it. So all the labs and things are done. We're just waiting for the medicine to get shipped to the pharmacy. Next. Some real world numbers for our program. And I was looking at the dates on a lot of our slides. A lot of the dates now are a little bit old. I think this last year kind of disappeared for us. It didn't look as bad when we were going to give this presentation in the fall of 2020, because it was, but now that we're in 2021, it looks a lot older. But we've screened a significant number of our adult patient population. We probably only have about 3,800 adults in the entire catchment area, and we screened quite a few of them already. Next. When we did screen folks, it was about 1 in 10 were positive for Hep C antibody. When we did targeted screening at the opioid treatment program, and again, that's about 280, 300 people, unique clients, that was significantly higher. So when you're thinking about where if you have limited opportunities to do screening or limited folks to do this, doing targeted screening can give you significantly higher rates of return in terms of identifying people who have at least a positive antibody. Next. Our cascade of care, it's a little bit dated now, but it does have some of the components that Jorge mentioned. I'd say our data now, you'd probably just add 20 to the number of cured folks, but looks about the same in terms of its trajectory. And the number retreated maybe is doubled from that, from 2 to 4, but it's actually really not that high, remarkably. Next. These, I think, will be discussed in future lectures, but when we think about the components of a Hep C elimination program, and we're talking about really what happens in the clinic, not this like global level about policy and stakeholders, which are extremely important, but this is really about what happens functionally inside the clinic building to operate. We think about these elements as discrete elements that need to be addressed to actually operationalize the Hepsi treatment program inside a clinic. Next, we'll just talk about one or two, mostly the harm reduction program. Next slide. So this is, I think, goes without saying for this group, but harm reduction is Hepsi prevention. As we get more and more safe injection supplies to folks, they're, even if they have not been treated themselves, it will it's less likely that they'll spread Hep C to the community. Next slide. For our harm reduction program, we took a really, it kind of parallels our Hep C elimination program because they did go hand in hand. 2014, at that point, it was just a syringe program. It was open like 1 hour in an evening. They were doing a 1-for-1 exchange. And in 2014, provided about 100 sterile needles. 2016, we brought the program into the primary care clinic, mostly through what Jessica Reemster was doing with us. And so patients would come for a normal primary care clinic, and they would, if they needed safe injection supplies, they would receive them as part of their primary care clinic. So it's embedded within the actual clinic. And at that time, we provided approximately 36,000 sterile syringes. Now we've moved beyond just the primary care clinic, but actually using secondary exchanges in the community. We have participants who have been longtime participants of the harm reduction program who now take excess syringes and safe injection supplies out into the community and give those out within their own networks of people who use drugs. And that kind of sprang up organically as people would come in, they'd ask for 1,000 needles, obviously not just for them, but for the people they use drugs with. And they would take those and distribute them out. And now we've formalized it a bit. We actually have 10 to 12 people that we pay a stipend each week to do training for harm reduction. And they do a 1-hour training, and then they typically will take syringes back or safe injection supplies plus information back to the community. And this last year, we provide over 300,000 sterile syringes, and this is for a population of 5,000. Next slide. The harm reduction program doesn't just help the Hep C program, it also helps all primary care for people who use drugs. And so what it's expanded to, because of the infrastructure that was developed for Hep C, is it's essentially an access point for primary care. And now we've expanded to offering buprenorphine for folks who access the program. People will come in regularly and do a quick start, same day access to buprenorphine and with no appointment. And we have about 100 patients, unique patients in that program right now, and that continues to grow. Next, the real key is besides harm reduction, but it's really connections with patients and making sure we get excellent follow-up and outreach for folks. Next slide, we'll just give you one example. This is from 2016. You know, the third patient that we treated. So at the, you know, when we were getting started, this was a huge deal. But the third patient we treated had a history of chronic Hep C from injection drug use. She had untreated mental illness, schizophrenia. She was homeless. She lived on a sailboat sometimes. She didn't have a car. She'd shower at the YWCA. She had no phone. She had no car. She was actively using drugs, and she was successfully treated for hepatitis C because our outreach team continued to engage with her. They found her at the YWCA because they know she took showers there on like a Tuesday morning. They met her there, got her medicines, and really that's what it takes, I think, to make these programs successful. Really taking that extra effort and figuring out what's needed for people and solving those problems. Next slide. So in 2016, we treated 3 patients in the whole year. That was the first year we started. It was clunky, it took forever, and now we're over 100. It's complicated to figure out what elimination means, as I think will get discussed. As your patient population is very different, those percentages are really hard to calculate. So some tribes in Washington have 300 people. So trying to hit a target of a 60% reduction in new cases is probably less meaningful than for a tribal population that has 100,000 people. So figuring out what elimination means for tiny programs, small programs, or medium-sized programs like ours is complicated. But I think that's what this learning group is going to figure out. Thanks.
Awesome. Yeah, I can't thank you enough, Justin and Jorge, for earning greatly deserved gratitude from the communities we serve and